High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. I am your host, Dr. Ronit Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts, hear stories from the emergency department, and listen to people who have struggled from addiction. Friends, fentanyl is plaguing America. It has infected all illicit drugs, from cocaine to meth, counterfeit pills, and even marijuana. If you're around someone who may be using drugs, you should carry naloxone, the opioid reversal agent. Carrying naloxone for drugs is like carrying an EpiPen for allergies. If you need a prescription for naloxone, you should have one. No questions asked. That is why I am offering a free prescription to anyone who needs one. Come visit me on hightruths.com to learn more about the show, submit a question, or download a free prescription for naloxone. And if you like the show, do me a favor. Give us a 5-star review and subscribe. Your stars are very much appreciated and go a long way in supporting the program. Today's episode is sponsored by ISAAC, the International Academy on the Science and Impact of Cannabis. Visit their website, isaac1.org, IASIC1.org, to follow the science on marijuana. Hello again, High Truth listeners. It's always a pleasure to get together for another trending episode. I'm your host, Dr. Ronit Lev. Trending drug use is important in interdiction and reducing supply, but also to keep up with treatment modalities. Whenever there's a new disease like monkeypox, I need to learn how to recognize the disease and treat it. And by the way, I've treated monkeypox patients now. It's not difficult. The pox kind of looks like chickenpox. But new drug trends are also important to track. I need to learn what symptoms to look for and how to treat that poisoning. And that's why I look to the medical examiner and law enforcement to learn what's out there. That makes me a better doctor. There are national sources for drug surveillance and trends that we learn about in this episode. And with that, let's hear our question of the day.
Hi, Dr. Lev. Thank you for having me on. For the listeners, I am Thomas Polveroni, an intern physician who has been very fortunate to work some very busy shifts with our host. Thank you for putting together this podcast and for your continued teaching about trigger point injections. It was very interesting to see a patient's sciatica symptoms instantly resolved after such a simple intervention. One thing I've noticed in the ED is the ubiquitous use of urine drug screening for patients presenting with mental health symptoms or in an altered mental state. Could you speak about whether there are other substances we should keep in mind that may not be covered by these tests but could contribute to the clinical scenario?
Thank you, Dr. Polveroni, for your kind words and great question. I love doing trigger point injections. They work like magic. Pain goes from 10 to 1 instantly when it does work. And to answer your question, by the way, I have an expert in drug screening, Dr. Eric Wish. Dr. Wish received his Ph.D. in psychology from Washington University and postdoctorate fellowship in psychiatric epidemiology. He is a national expert on drug trends, and he supervised the development of the Drug Use Forecasting Program in 2013. He developed the Community Drug Early Warning System, and the following year he established the National Drug Warning System called NDEWS, NDEWS. He is now director of the Center for Substance Use Research at CESAR at the University of Maryland. You can find Dr. Eric Wish's bio on the High Truth show notes. Dr. Wish, welcome to High Truths.
Oh, thank you. It's so nice to be with you this morning.
I know. I've been looking forward to this interview. You and I have worked together on interesting projects that I want to share with our audience, but I want them to get to know you first. So tell us, how did you choose a career that ended up looking into drug trends?
Well, I got into the drug area because I was at Washington University in St. Louis studying in the psychology doctoral program. And I heard there was an NIMH drugs and addictions traineeship, and, money's going to attract you, I guess. So I needed funding. So I went there. And while I was there, I basically had to do an internship. So everyone said to me, you've got to go and see this person named Dr. Lee N. Robbins in the Department of Psychiatry. So I said, yeah, I'll go see him. Well, it turns out it was not a him. Dr. Lee Robbins basically trained me in research, and I worked with her on the Vietnam veteran follow-up study, and I got my doctorate, then did a short NIDA postdoc with her, and then moved to Washington. And while I was in the Vietnam veterans study, I met the who's who of the drug field, including Dr. Robert DuPont and Dr. Jerry Jaffe and the late David Nurko, all of these greats in the drug field. And I came to Washington, and I worked with a firm, a nonprofit research firm, where I inherited a study to look at drug test results from the DC pretrial testing program and relate that to criminal justice information, case information. And the person who basically funded that project, by the way, was Dr. Robert DuPont. I say everything I do is based on his great ideas.
He's awesome. Shout out to Bob.
Yep. I take his ideas. He was first director of NIDA, as you know. Anyway, while I was there, I was basically linking the urine test results from people who had been arrested and tested with their criminal histories, and did some reports. And then I moved to New York and sort of replicated what we did. DC has been testing people for drugs since around, actually Bob DuPont started it. I think it was April 1st, 1970, and they tested everyone until recently, everyone who's arrested and charged with a criminal offense. So I went there and started a research program. I was funded by National Institute of Justice to basically collect urines. We went into Manhattan Central Booking and collected urines from arrestees, and we created we showed that it was possible to do that. And then in 1986 to 1990, I was a visiting fellow at NIJ, setting up what was called the Drug Use Forecasting Program, was renamed the ADAM program. So the Arrestee Drug Abuse Monitoring Program. And the idea was that if you could collect urine specimens from people who are being arrested and who are high risk for using drugs back then, and then sort of do that every quarter and chart that's CHART with a Boston accent. You could chart it and you could track drug trends. So we did it in Manhattan, and they used to say, once you do it in New York, you can do it anywhere. They brought me down as a visiting fellow, and we established those programs. And when I left that project, I know this is a long answer, but I hope it's okay for you. When I left that project at NIJ, and it lasted for about 15 years. And it was international. It was in about 25 booking facilities around the country. I basically took over a new center at the University of Maryland called the Center for Substance Abuse Research, or CESAR. And while I was there, I found out that I would visit jails professionally, and they would all say, Dr. Wish, look at our urine testing equipment. And they would show me that we went to one local jail, and they said, look at it. And I said, that's great. And then I said, what are you testing for? And it turns out they were testing for the drugs of the old epidemics. All right. And I said, can you test for this and this and this? And they said, no, we have a contract with the state, and this is all we can do. So then, of course, I said, can I have some? What do you do with these when you're done? We throw them out after 30 days if they're positive. Otherwise, we throw them out quickly if they're negative. I started collecting urines in Maryland from the testing program. And then we had the idea.
What year was that?
Oh, I think it was about 2005, 05.
So fast forward 15 years, we still have the same problem of testing the wrong things.
We still do. So basically, I enlarged that program, and then showed that instead of going in and sending researchers in to collect urines, why not collect urines that are already collected by operating testing programs, and then just test them for drugs. So we did that. And then ONDCP, the Office of National Drug Control Policy, got interested in it, and they funded us to go to different places other than criminal justice, some hospitals and whatever. So we went to treatment programs, and we basically found that basically around the country, people don't test for the drugs that are out there. They have a contract, and they just test for what they have contracts for. So then we moved from that into now something called the Emergency Department Drug Surveillance Program, which we are now launching. And that's how we met you, through ONDCP, because you had been there. And you helped to set up the program in California, or in your hospital. And we have it in Maryland, and we have it in 5 hospitals outside of Maryland. I just want to share with your viewers that when we first got the results in our pilot study from the Baltimore hospitals, Baltimore is known for having a big heroin problem there. We looked at the opiate screen results, and they were like on a 45-degree angle coming down during what was an opioid epidemic. So what was this? So we looked into it, and we thought, well, gee, maybe they're using fentanyl. The opiate screen that everyone is using across the country does not pick up fentanyl. So one of the doctors, Dr. Zach Desmond, basically did a dipstick test. He bought his own dipsticks for fentanyl, tested some specimens before he sent them to the lab, and then compared the results. And those results basically showed that the opiate screen, that the hospitals were missing a large percentage of the people who are testing positive for fentanyl. And basically, because of that research, which was published in MMWR and in another medical journal, the 2 hospitals in Baltimore started testing for fentanyl. And it's so rare that you do social science research and you really affect policy, and they did. And then we included those hospitals in the EDDS study. And what we found was, since they started testing for fentanyl, that 85 to 95% of the people coming in, the overdose people coming in and being tested, test positive for fentanyl. And the next highest drug is cocaine, and then 40%. So they were missing the drug that most people were testing positive for. So with that, ONDC expanded us. We started to look for hospitals outside Maryland, and we're doing that. And now this year we're expanding to about 17 hospitals. We're working with the group HCA Healthcare, and they're an umbrella organization of about 182 hospitals, and they're helping us to get the approvals. And we're in the process of collecting that information now. And the results from the program are just amazing to us, because first of all, you find that just about no hospitals testing for fentanyl. I know you're in California, in your hospital, you can request it, special tests, but the routine panel doesn't include that. And it's kind of amazing to me that in a country where we know that people are dying from fentanyl every day, that the hospitals aren't testing for it. And you know what they say, and I'm sure you can talk about this too. A lot of times the ED physicians will say, well, we don't test for everything, and we don't care because we test for the symptoms. We have to treat the symptoms, they say. And the point is, if you do the testing, now you have information so you can tell your patients, you were using fentanyl, or fentanyl is very available out here in this community. And it's great public health information. And it's sort of like, now that we have COVID and you say you have to test in order to track the trends, well, you would want to test for fentanyl just so we can track the trends and track the outbreaks. So anyway, sorry, that was a quick answer, but go ahead.
No, that's that's all very important. And you said so many things that I want to comment about. I want to let our viewers know now, 2022, people know, okay, of course we know we have a fentanyl epidemic, but your study in Baltimore, and getting those hospitals there to start testing for fentanyl, that was several years ago. You were on top of the trend because of your study in surveillance in drug use.
Right.
And so what we've done with that, and I'm so honored that we got to be part of your study also, is move that to action. Just like you said, you've done studies and now to policy. And we did that in California. And I don't know if you know, but from those studies, we I called all the labs in San Diego County, 24 hospitals. They were all working very hard on COVID. And I said, you need to work on fentanyl too. Maybe at that time, COVID was number one, but fentanyl number two. And within 10 months, the majority of hospitals in San Diego County were testing for fentanyl. And we wrote a bill, and it's going through California legislature with unanimous support, SB 864, fentanyl testing, Tyler's Law. And we expect this to pass very soon, August or September, to be signed by the governor, and every hospital in California will be including fentanyl anytime they do the drug test. So that's I'm excited about that, and that originates with this type of drug surveillance that you're doing clinically. It's so important. The other thing I would say, when you talk to doctors and they say, "Oh, we don't need testing," I tell ER doctors, and I'm one of them, I said, "You're right. You don't need to test. When you have someone," I'll tell you an interesting story. I don't know if it belongs in this podcast, but I just worked last night at 11 o'clock at night. I was done with my shift. I closed my computer. I got my bag in my hand. I'm out to the door. And the nurse grabs me because my patient stopped breathing. What do you mean my patient stopped breathing? I admitted her with a hip fracture. I had her all tucked away to be admitted, the orthopedic surgery in the morning, everything all done. She stopped breathing. I gave her one Dilaudid, and I immediately ran, gave her naloxone, reversed it. So do I need to know? I don't need the drug screen to know what to do, but I do need it. The difference is being a good doctor, right, which I just did, being between that and being a great doctor in knowing how to make sure that doesn't happen again and educate the patient, right? So there's treating the acute condition like I did last night, versus, okay, now I got to think, why would only one Dilaudid do that? Or why did that person overdose? How do I convince them to change? All that helps, data helps with that. So that's what I tell ER doctors when they say, "Oh, I don't need a test." It's like, yeah, we don't need a COVID test either. We don't need half the tests that we do in order to treat people. But that added data point sometimes makes a difference between a good doctor and a great doctor.
Well, I'm so excited to learn all of the changes that you've created in your county, and I would ask that you put that in writing and tell ONDCP. They always need to know why this project is important, and we need that information to be communicated to them. So thank you so much. It takes, throughout my career, it's like, you've got to connect with visionary people like yourself, who actually will run with the stuff and who will basically go further, go beyond what's generally known. I think it's great. I wanted to add one other contextual thing, is that one of the studies we did in Maryland a few years ago was there was synthetic cannabinoid outbreak, and everyone knew it, and it was in the press. So we asked 2 other hospitals to send us urines to test from people that they believe.
And synthetic cannabinoids, just for our audience, that's like spice and K2.
Right.
It's not really, it says synthetic marijuana, but really it's made in a lab. It's not real marijuana.
Yeah, I tend not to use synthetic marijuana because people then think, "Oh, it's marijuana and that's legal. How could it be bad?"
That's true.
So we basically tested the specimens from physicians who basically thought, for the most part, these people had taken the synthetic cannabinoid. And what we found, we sent them to the independent laboratory, and only 20% tested positive for synthetic cannabinoids. It was fentanyl and cocaine in Baltimore, and it was PCP in Prince George's County, Maryland, which has been known for having a PCP problem. So basically, what I wanted to just tell you listeners is, a lot of the data systems we have basically are using clinical records. In other words, what the patient or an observer or the doctor thinks the person had taken, and not necessarily based on testing. But people don't know what they took. Sometimes when we tested specimens, they tested positive for 15, 16 different substances. So you need to do the testing. And that's why this EDDS project that we're doing is so important, because it's focused on what what people over time, what the trends and what they're testing positive for. But because we know that the hospitals only test for a few drugs, we sample specimens de-identified, and we send them to a lab and test them for 500 drugs. So every hospital can then get a report saying, here's what was found in the specimens that tested positive for anything in your panel versus those that tested totally negative.
And that's so important, because that does make me a better doctor, because I could just, kind of treat people's symptoms. But if I know what's going on in the community, then, I can focus and do better. And, since I've increased testing, and I probably test a little more than maybe other doctors, I use that information with patients, and patients are very interested. Some aren't, but some are like, oh, I had a guy said, no, it was just marijuana. I swear it was just marijuana. It's like, you have no marijuana in your system, but you have fentanyl in your system.
Right.
And you could see that patient pause and wonder, that's not what they expected.
No, we've done other studies where people are shown a test result and asked whether they used the drug, and they said, the dealer must have put that in. I didn't know it. So that's the way it is now. And that's why we say, with the studies we did over time, we were able to actually document the different synthetic cannabinoid metabolites that are out there. That, we were able to go on the media and tell people that they were playing Russian roulette when they used drugs they thought were like synthetic cannabinoids, because the people who make this are continually changing the molecules so that they're legal. Because, so anyway, it's
very important, because drugs keep changing minute to minute. And if we don't keep up with that, it's not just for the data. For me, data, some people like data. I want to know what to do when the patients come to the emergency department so I can act, right? So I think that makes a clinical difference to how we improve treatment of patients.
Right. Well, as an epidemiologist, my focus is on, can I track the trends, but the information then gets down to you to help you with your patients. I think it's absolutely critical. I wanted to tell you something else that just happened. The state of Maryland has just given us a grant, basically a cooperative agreement, to create the first statewide EDDS project. So we're going to create the EDDS program in 20 hospitals in Maryland.
So tell us again, EDDS stands for Emergency Department Drug Surveillance.
Yeah, we're going to put it in 20 hospitals, and in the 18 that don't test for fentanyl, we're going to do the dipstick test. They're going to send us a small sample of specimens, about 50, and we're going to test them for fentanyl. Well, actually, we're going to do it there. We're going to do the dipstick test before the lab is done with the specimens, basically.
Well, on one hand, I'm jealous because you got all your state to be involved in your study, and you test for 500 different drugs, not just fentanyl. Right. On the other hand, I'm disappointed because they should simply do what we do in California, is they should all be testing for fentanyl. That shouldn't be an extra thing. If you're checking for PCP, why the heck would you not be checking for fentanyl? And it costs 75 cents. And if the state of Maryland, if any hospital wants to learn how to do it, I have a toolkit. I can help them figure out how to buy the reagent. Anyway.
Well, I think now we're going to find out, by taking the small sample specimens, we'll find out where there probably is fentanyl throughout the state of Maryland, because it's a very diverse state. And then the hospitals that are missing it can decide to adopt the fentanyl testing. And that's when we'll bring you in.
Yeah, even rural hospitals wanted to get an exemption in our law for not test for fentanyl. And our legislator actually had it right, saying, but people are dying in rural areas. Yeah. Maybe the test will cost $1 in your hospital instead of 75 cents in a busy hospital, because there's bulk purchasing. But that's still, still so important. So Dr. Thomas Polveroni, he's an intern who I work with in the emergency department, very enthusiastic. And he noticed that we order lots of urine drug screens on patients with mental health and issues and altered mentation. And he wonders if there are other drugs that we should keep in mind that do not show up on our routine drug screens that could contribute to clinical scenarios. You mentioned One, the synthetic cannabinoids. We do fentanyl now. When we first started the project, we did it only on occasion. Now we do it all the time. But are there other drugs? You're testing these urine samples from on hundreds of things. What else are you finding?
Oh, well, you get a lot of the prescription drugs too, but we can't tell easily if it's been prescribed or used, in under physician supervision. But one of the things that you would think people would be testing for that not everyone is testing for is marijuana. It's like we find a substantial minority of people who, when we test them for 500 drugs, they only test positive for marijuana. It raises questions in my mind. And I know there's been some research published recently that maybe there's some issues around use of marijuana in terms of psychoactive issues, in terms of medical issues. And I find, for the most part, people aren't interested. I don't know what the reason is. I know they don't want to test for nicotine because they say, oh, everyone's using. But when you have a huge expansion of marijuana use, like what we're having in this country, maybe we should at least do some research to ask these patients who test positive for marijuana how they think maybe it affected them, especially if all they test positive for is marijuana. So I'm not sure that's the drug you wanted to talk about, but that's one that really is.
Let's talk about that, because that's very important. I noticed when you did the 5 hospital study that our hospital was part of, even Colorado, one of the first to legalize marijuana, they removed THC from their drug screen. So they got all these other drugs and they consciously took that out. So when you look at their drug trends, it looks like, oh, well, they don't have a marijuana problem. While in my hospital that does test for marijuana, 50% of all drugs were positive for THC. And we know that THC is becoming much more potent. Back in the Vietnam era, when you started your career, that drug was 3% THC. Now you go to dispensaries, you could buy 98% THC. People on that behave more like they're on meth. It's not a mellow drug anymore. And I actually think it's malpractice because those hospitals are missing cannabis-induced psychosis, cannabis hyperemesis syndrome, and things that are evident with that data. I would call them on it. I would call them on it, and they shouldn't be part of your study if they're not, if they're consciously making a political decision instead of a science decision with their drug testing.
Well, in our study where we collected urines, 150 urines, 100 hospital positive and 50 hospital negative for their screen. We found, I think the remember was around 30 to 40% of them of each group tested positive for marijuana. So when you talked with them, did they give you any rationale for why they took it off their panel?
The Colorado ones it was a political decision. They they don't want people I think they want to show that's not a problem. If you don't measure it, then it can't be a problem, right?
That's right. Remember, that's talk with COVID. You don't measure it, you don't have a problem there. You have less of a problem, right?
Right. But they're doing a disservice to their patients. I talked to a mom whose son went to that same Colorado emergency department with a psychotic break, and got admitted, got stabilized, and then left and very sadly committed suicide. But they'll miss the diagnosis of cannabis-induced psychosis, which is I think that's a type of malpractice for and that's letting politicians practice medicine, which I don't think is right also.
Yeah, well, we haven't been able to do this yet, but we do have the information in our database on diagnoses. So we could look at that among the marijuana positive people, see if they have anything like those illnesses that you just mentioned.
Yeah. There are other things, bath salts, xylazines, fentanyl analogs, synthetic benzodiazepines. There's a whole bunch of stuff that you test for that we can't do in the hospital that could be affecting clinical scenarios.
You know what we find a lot of that we're hard to explain it? Gabapentin keeps showing up. And there have been some issues around that, but I don't know why there's so much gabapentin showing up in these people. That's one of the drugs. Yeah.
Gabapentin showed up high in mortality data when I researched patients who died from medications.
Yeah.
Gabapentin was up there, and it was harder to tell if it's prescribed because it's not a scheduled drug. So I was able to compare all scheduled drugs, like the oxycodones and the benzodiazepines. But since gabapentin is not scheduled, I could not tell if it was prescribed or not because it is a commonly prescribed medication.
Right. Yeah, well, we have been finding it for years, so we don't know what's behind that. One of the other interesting things that we found is when you look across hospitals, not only do their panels differ a lot, the drugs they're testing for, but the cutoff levels they use are not standard. It's like we really need a standardized set of drugs and cutoff levels that are used across the country, so that if we want to be able to track things, otherwise we're comparing apples and oranges. And lots of times we find a lot more drugs, even of the drugs that the hospital tests for, we find a lot more people positive for it because our lab is using much more sensitive tests. So
yeah, you did that at our hospital, for example. We very sadly, you found out for us that I call it, we're the capital of methamphetamine. 76% of all the drug screens that we did were positive for methamphetamines. And then you pointed out the cutoff level, because even our negatives, you found that half of our negatives were actually positive, but our cutoff was so high that we were missing it. Yeah.
So, I really think we need a national system of doing this, at least of hospitals, the way they test, so that we can combine the data and can actually track the emergence of these drugs around the country, the ups and downs of them. Because it's kind of crazy that we don't do it. It's really unfortunate that we don't do it.
Yeah. And again, that does make a clinical difference, or at least to know. I mean, it's hard to standardize things amongst hospital. I don't know if we could ever do that. But for me to know that if I have a patient who's acting strange, and even if my tox screen is negative, my cutoff is high, and that's why I'm missing it. So just knowing that is powerful.
And the other thing we haven't talked about that I think is critical is as I say, I've been involved in this type of research since the 70s. And it's like, we love to villainize a drug. We blame it on the drug and we focus it on the one drug every time. Remember the crack cocaine, it was heroin, it was crack cocaine. And what we find when we do this testing is we rarely find something like fentanyl. You're not going to find that being the only drug. Now, again, these are people coming into the hospital, emergency department, so they're having problems. But all I'm saying is there are multiple drugs that are found, and we should be looking at that, not just focusing on the one drug that people tend to use. I oftentimes say it's the person, not the drug. In other words, it's likely that there are some people who have a disposition for using these drugs. And we need to be able to figure out who they are and to work with them, because you don't want to just treat one drug or focus all the attention and resources on one drug.
Yeah, that's true. I mean, fentanyl is killing people disproportionately, so we probably do need to focus on that. But I absolutely agree with you. And we can't have, when I was at ONDCP, Office of National Drug Control Policy, part of the White House, there was focus just on opioids. I made a point that we should, spend that money also on methamphetamines. We were creating protocols to taper people from opioids. And I said, that's great, but we also need protocols to taper for benzodiazepines, because that's much more difficult. And what happens is we just leave those patients with no resource. We have to take a collective approach of everything. There are some things related to just the drugs, like treatment, but you're right. When it comes to the human being, of why they're using drugs, and it's not the drugs and the actual chemicals themselves. It's the person and the disorder that needs attention.
Yeah, I did some research over the years where I took survey results, big surveys, and I basically looked at if you tested this was self-reported information in the surveys, but if you said you would use a particular drug, how many other drugs did you use? And if you lined up the drugs from the very prevalent drugs, starting like at alcohol and marijuana, and you line them up, looking from them down to the ones that are very rare, that was like heroin, even methamphetamine and PCP. Basically, the rare drug, it was the rare drugs, the rarer the drug, the more drugs the person had used ever, lifetime. So the correlation between the prevalence of drug and how many drugs the person had used was like minus 0.95. So in other words, as you got less and less prevalent, you got more and more drugs that the person had used. Is that clear? So,
yeah, that makes sense. Because if you're not going to start with the rare, you're going to start with what I do in my personal study of hundreds of patients in the emergency department that I have not published. Yeah. I ask everybody, how old are you when you first started using drugs, and what was the first drug you ever used? And almost 100% of people who were using fentanyl started out with marijuana. And sometimes they even dismiss it. Oh, well, that was just marijuana. Yeah, but you were 12 years old. That started that started your brain into addiction, and that matters clinically because I kind of estimate how long they need to be on Suboxone for. It's like they're not going to be on it for a week if they've been using drugs, including marijuana, since a young age. They're not going to reprogram their brain that fast.
Right.
What about xylazine? We're seeing that on the West Coast, but my counterparts on the East Coast saying they're seeing that a lot with fentanyl, which makes the reversal and treatment more resistant of having xylazine with the fentanyl. Are you seeing that?
I know we're testing for it, but I really don't focus so much on it that I can give you much information on it. But if you get back to me and we talk afterwards about it, I'll try and look that up. It's the more prevalent drugs is what I'm prepared to talk about now.
Okay. Yeah. And do you see all the other different drugs like bath salts and there's new benzodiazepines out there? Are you finding those things as well?
Yeah, we just got an inquiry from FDA, and we have to look at the molecular structure right now of the benzodiazepines, because we do test for a variety of those. But I don't, right now we're in the process where we're still trying to expand and collect more data, and I have a very, very limited staff. The funding for this project is infinitesimal. So we're a small group, but we're hoping at some point, given that we have all this data collected, that we'll be able to get some resources to be able to have more people look at it. You're asking wonderful questions.
Yeah. You're small but mighty. I've met your team. They're amazing.
Oh, they're phenomenal. I'm very blessed to have these colleagues to work with.
You started out telling us about this Vietnam veterans drug study that you're involved in. Can you tell us about that? Sometimes we could learn something from history.
Oh boy. Well, that was a classic study because, and it was Lee Robbins. She was a genius in the drug field. And we found at that time, there was a real question whether the vets whom we were known were using heroin, whether or not it was their addiction. We thought, from media reports and from reports from the field, there was a lot of addiction, but we didn't know, we didn't have really good numbers. So they went to Lee Robbins and they asked her to do a follow-up study of all service men coming back in September 71. And she did a phenomenal way of sampling them. And literally, NORC did the surveys. They found 94% of the target population. They interviewed them. This was a year after they returned to the States. And they found while there was a lot of addiction, a lot of use and a lot of addiction, that I don't remember the numbers offhand, but when they came home, they basically remitted even without treatment. All right. So the question was, there was a lot of criticism at that time, basically, oh, you didn't study them right, or you didn't study them, you didn't wait for them to be home longer. You should have had a longer follow-up period. So basically, we followed them up again 3 years after they were home and found the same results. And now we know it was actually true that that didn't spawn a big heroin addiction problem in the States from the Vietnam veterans. It really sort of dissipated. And it wasn't because people couldn't get it, because they told us that most of them knew where they could get heroin if they wanted it. So it sort of raised some big issues back then about why, and Lee wrote a lot of articles about it, but why did these people who had the symptoms of addiction come home and not have, most of them not have serious problems resulting from it? I can tell you, Lee's, she was a sociologist in the psychiatry department, and she was very well known for what was called back then deviance, behavior problems and whatever. And what we found was that the people in Vietnam who got into trouble with drugs, you could basically find them by their pre-service risky behaviors, school problems, fighting, even some drug use. So it got back to certain people for some reason being more disposed to having the problems with drugs. The other thing is that, and not everyone agrees on this, but the idea is you wouldn't characterize everyone's sort of experience with alcohol by just looking at the people who were diagnosed with alcoholism. They may be very different. But everything we knew about heroin addiction back then came from studying people basically in treatment, the ones who got in the most trouble in it. Whereas here with the Vietnam veterans study, we were looking at a quasi-normal group of people. You couldn't remember back then, you're probably too young, but back then you couldn't be drafted if you had a criminal record. So that the people who, it was like a natural experiment where a quasi-normal group of people went to Vietnam to a heroin-rich environment, you could see what happened. And, I urge people to go back and look at the studies if they want, but it was quite an experience to work on that study and again, you found the polysubstance use. That stuff hasn't changed at all.
Dr. Jerome Jaffe, that you've kind of mentioned, he's also was one of the nation's first. Actually, he's nation's very first drug czar, psychiatrist. He was a wonderful mentor to me while I was at ONDCP. He instituted a policy during that era when President Nixon came to him and said, what do we do? We're going to have this problem with heroin. And he came up with the idea to drug test the veterans while at Vietnam before they come home. Yes. And if they were positive, they'd have to wait a week before come home. Yeah. What a great motivator.
I know.
Right? It worked.
Comes back to drug testing again.
Yes. I mean, it's a prevention tool. It's a deterrent tool, right? It was important. So I thought that was absolutely brilliant. I don't know if it'd probably maybe controversial today if we did that, but I thought that was, really a brilliant idea. And he also did point out availability. Yeah. Because supply matters. We have so many people on methamphetamine in San Diego because supply is everywhere. And with increased supply, there's increased use. And so we can't discount the fact that when the veterans came back, the supply of heroin was not as great as it was when it was where it was in Vietnam. They said, okay, well, I know I can find it, but that's just different than having it everywhere, right?
Yeah, there's just so many hypotheses out there as to why it happened. All we can say for sure is they got the symptoms of dependence in Vietnam. When they came home, they remitted.
Yeah.
pretty much.
Yeah.
It didn't matter whether
Supply,
they.
and then the other theory I think that I've heard a lot is they were with family and a social support
Right.
that is important. And we know that that's definitely important when it comes to drug use.
Absolutely. By the way, Dr. Jaffe was the head of CEDAP, the President's Special Action Office on Drug Abuse Prevention, which became the forerunner of NIDA. So he stepped down from CEDAP, and Bob DuPont became the first director of NIDA when they formed it. So it was all connected.
Yeah,
yep. They're both brilliant men.
They are, and they're around today, still vibrant. Both these gentlemen. Dr. DuPont has been on this show on High Truths, and Dr. Jaffe. He's been such a great mentor to me. He's less of a public eye. He doesn't want to do that, but he's still very vibrant and knowledgeable.
Yeah, I remember when he was director of the NIDA Intramurals Research Center, and I was talking to him, and he says, I don't know how it came up, but he says, you know why I do so well? I always hire people who are smarter than I. And I said, I don't believe that at all.
He's amazing.
Yeah.
So I want to say thank you to Dr. Thomas Polveroni. I wish you the best in your medical education and hope you have a chance to do a trigger point injection in the future. It was fun to work together. And Eric, Dr. Wish, thank you so much for your interesting history and education. I'm really very thankful, and I feel privileged to have been part of that Emergency Department drug surveillance study. Really an honor to be part of that. And you need to get more funding for your work. We need to stay on top of the drug trends. No data, no solutions. So that's important. Thank you.
Thank you very much. It's been a pleasure and a privilege to work with you. And I've learned a lot from our discussion. I didn't know you knew so much about the history and the Vietnam veteran study, but also the way you have gone and used the results from the EDDS project is just phenomenal. I'm so happy. And I want to urge your viewers to go to CESAR.umd.edu, and then you can go to the EDDS tab there, and you can get all the results that we have on the EDDS project.
That's great, and I will post that information on the show notes.
Fantastic. Thank you so much.
Thank you for listening to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. This week's episode would not be possible without the generous support from our sponsor. A sincere and warm thank you to ISAAC, the International Academy on the Science and Impact of Cannabis, doctors educating on the harms of marijuana. Visit isaac1.org, IASIC1.org, to view their medical library, translated for public understanding, listen to their speaker series, and follow the science. Our producer is Dave Rivas from Davey Boy Productions. I am your host, Dr. Ronit Lev. We hope we brought your day a little bit more high truths.